Bueno, la idea original de
Okay, well, the idea behind this roundtable of sorts is just like last year, since we have experts from different domains, Gloria from clinical therapy, Marina, who's a hepatologist. Maybe it is the perfect setting to ask questions, especially about what is going on locally. So, questions. All right, over there we have one question. I would like to ask the following question. Is there a relationship between pregnancy and cholestasis? Are both symptoms related at all? Well, we collected data in pregnant women with Wilson, and specifically, I don't recall that the results mentioned cholestasis. The most relevant outcome, and Esther, you were involved, so please come in if I'm mistaken. Patients who took the medication well and were well controlled had good pregnancies with no problems and term, but in patients that were not controlled suffered problems and there were some miscarriages, and that was the result of the study, if I'm not mistaken. I don't remember anything specific about cholestasis and pregnancy. I don't know.
Experience, both of you, with cholestasis of pregnancy in patients with Wilson disease, pregnant women with pregnant Wilson women that develop cholestasis of pregnancy? Because I don't have any experience with that, but
So we've got a large cholestasis cohort at King's. So cholestasis can be from pregnancy itself. It doesn't have to be.
yeah, I know. But if the women that are with Wilson disease, they have more.
I haven't seen that.
And I haven't seen that. No, en principio ellos tampoco han visto. O sea que
Same here. I do not have experience in that, and in the Spanish registry, we've not seen that, no.
Or mutation in MDR3, no?
It is important that the therapy during pregnancy does not get stopped.
That's what I was just really saying, that what they need to be, lo que estaba
So that's what I was saying. What is of the essence is for women to be well controlled during pregnancy, to avoid interrupting or withdrawing the medication out of fear. What is especially important for these pregnancies to be successful and is for there to be a good control of the condition. A microphone, please. We cannot translate otherwise. The reply is precisely some women were diagnosed during pregnancy, and a high percentage of those pregnancies ended in miscarriage, but that's because of the late or lack of diagnosis. But it's all about controlling copper, having a good control with medication for the pregnancy to be fine. Again, the interpreters apologize. We can only hear if a microphone is used. I've had two cases. We don't know what, and there was cholestasis during pregnancy. I think they're probably two. Those are probably two different things. The cholestasis in pregnancy. I don't know, maybe we need to look into that more. Any further question in the room? Hello and good afternoon. I have a question for any of the three speakers. Can symptomatic Wilson disease patients also have schizophrenia because of the psychopathologies related with Wilson's? I think Aurelia might be able to answer better. I have patients with Wilson's who've developed psychotic symptoms, and they were well controlled, so that was striking. They were not patients who I thought were not well controlled, but maybe Aurelia can tell us more because she's a neurologist.
I'm a neurologist, not a psychiatrist, but anyway, a different type of psychiatric disease have been described in Wilson's disease. Schizophrenia is part of them, so it may exist, but I don't really know the percentage of, I don't know if it's frequent or not, so, and we don't have the data for that. But psychosis and patients who develop many symptoms of psychosis and then they develop a real schizophrenia have been described, but in my experience, it's not so frequent. The more frequent is more anxiety, depression, and this kind of symptoms.
I was telling him that I have a couple of patients with psychosis. One was because he was diagnosed through the psychiatric problematic, but one developed the psychosis under, in theory, adequate treatment. And I was very surprised.
We have the symptom psychosis, but then the real schizophrenia, you know, it's maybe...
I understand,
The symptoms, the psychosis may happen, absolutely. We have few patients with this kind of presentation, and usually decrease with the treatment of the Wilson. It's better. It takes time, many years often, but it takes time and decrease. But a real schizophrenia, I think it's rare.
Buenas tardes.
Good afternoon. I have a question on botulinum toxin, or Botox, because my eyelids fall. I can see, so it's not completely, they're not completely blocked, but there was a time when I had this descended eyelid, so they used Botox or botulinum toxin to lift my eyelids. I spoke to my doctor, and if the eyelid falls too low, I'm not saying completely closed, maybe you can undergo surgery, and the physician said that would be for extreme cases. So I get a shot once a year with botulinum toxin. And after a month and a half, I start to feel that the eyelid starts to lift, so to speak. So my question is, do I need to wait until I can no longer see? Or what do you think about a surgery? That's my question. Thank you. Aurelia might complain, but I think it's more neurological. I don't know if she has experience. I don't have a clue, but I think that we need to be as least invasive as possible and go from less to more invasive. So if the toxin is working, I would go for the toxin and leave surgery if that fails. But I don't know. Do you think it has a relationship with the disease? Let's see what the doctor has to say.
Ready to become a neurologist, I think. Yeah, toxin botulinum is the treatment for dystonia, and blepharospasm, which is the when the eyelid close, is very typical from dystonia, eyelid dystonia. So toxin botulinum is very effective on that. And usually we do it at each 3 months, but we cannot do it in a shorter duration. So you have to wait 3 months. But yes, do it because it's very effective and it's a local treatment, so not side effect. The eye can be dry, so usually we put some ice drop, for. Plus the toxin botulinum, but yes, do it. And surgery is for my colleague told you, surgery is really for very severe blepharospasm that are resistant to toxin botulinum. Dr. Aftab.
Just coming back to the psychiatry presentations, we've looked at 50,000 patients at the Maudsley in London, and I think the Maudsley is one of the largest European psychiatric units in Europe, and in that population we found a number of schizophrenic patients, so it is probably more common than you might think. And there are variations of psychiatric presentation, from psychosis to cognitive dysfunction, to lack of concentration, to change of personality. So it's probably a lot more commoner than you think, and probably more commoner in the adolescent population and early 20s, particularly in the early presentation when it masquerades as psychiatric presentation, and so the diagnosis is often missed with the schizophrenia and so forth. And it can be delayed.
And my question is always, if in this, I completely agree with you. We know that there are misdiagnoses. So in the psychiatric units, they do not perform seroplasmy to all the patients. I'm just going to talk, my oldest child had one of these trastorno por hiperactividad, hyperactive. Now it was very common. Everybody, all the children now, adolescents have this. But if you think about it, why wouldn't they do a blood test? I think they should have done a blood test, maybe to check. I mean, I understand Wilson. It's the only disease that I understand from the.
Yeah.
And it was never done.
Yeah.
So I just wonder whether we are missing an opportunity in the psychiatric units.
I mean, I definitely think we're missing an opportunity. So you don't necessarily have to do a seroplasma on every single patient. You could be more focused. So what we found was doing a seroplasmin on those patients who presented with deranged liver enzymes, with the psychiatric presentation, and with a specific, we've got 4 or 5 high index suspicion, symptoms. And if you come to our poster in ASLD, we can go through that, and in the manuscript.
Yeah, thanks.
Okay, no, ya no.
I would like to share a case. I am the mother of a patient of Wilson and a daughter to a schizophrenic mother. And apart from schizophrenia, my mother died of hepatitis C. So I included her in the liver transplantation program, and she was not accepted because of the psychiatric symptoms. And when the doctor announced this, she was in a terminal phase. She was a part of the psychiatric symptoms on a wheelchair. When the doctor, when he announced this, asked, has she never been diagnosed with Wilson disease? I said, I don't know. Do you know what I'm talking about? And I said, I have no idea, and explained it had to do with copper, this and that. And he said, okay, it's all right. Don't worry about it, because she had been diagnosed with hepatitis C, which, and back in the day, there was no cure for that. And then my mother died, and when we discovered that my son had Wilson's disease, I had my mom's blood tests, and I started to see if there was ceruloplasmin anywhere. Well, once my mother had passed, and there was not a single blood work with ceruloplasmin. I thought, well, my mother having two genes from the mother and the father was very infrequent. But since you're raising the topic of schizophrenia, I thought it was interesting to share this story, because perhaps we should pay more attention to this. Well, the conclusion we're drawing here is that there does not appear to be a relationship, but out of ignorance, because we do not have ceruloplasmin or a sample of tissue. But a grandmother with Wilson's transmits one of the two genes to all the offspring. In the third generation, you're second, so you carrier. If you have offspring with another carrier, the third generation of your mother would be your children are at a risk of having the disease. It's more tricky to demonstrate schizophrenia, but that some of the parents of the child, the chances that they had Wilson, the odds are very real. I have a question. So this morning, I think I understood that this idea of a single dose for the medication, that they're running tests, and it's clear that it's probably going to work. But they ruled out that monodose does not, a penicillin monodose does not work. Do you have patients, Marina, on one dose? Well, with Wilson, you try everything. Even with the Will thing, there's this paper published of patients treated with one dose of zinc a day. And depending on how patients do, I've brought down the dose of Will thing, not penicillin. I don't remember decreasing the dose, but when I've done these things, it was in response to an adverse event that I thought perhaps the patient was too decoupled, so had too low a level of copper, so in response to something, right? And when I do that, there's a very close follow-up. If I know there's a drug and they say this works 24 hours, and I see a study that shows that, and that I'm going to deliver this and I'll have peace of mind, I will convey peace of mind to my patients too. But when I try these things, I don't convey that peace of mind because I do not have peace of mind myself. So okay, I'm clear. So that the recommendation is to take this in several times to have a good effect. Well, we've learned. First, it was 3 times. Now it's twice. So things change, but we need scientific evidence. The thing is, with Wilson, up until not long ago, that we didn't have true trials. In medicine, we've learned that everything has to be backed up by RCT, so that you can do this. And if you don't have one such study, you're always nervous because it's like you're cooking, with I don't know, but in no time we'll learn the results of a good clinical trial, well done with one dose a day, and that will give us peace of mind, and hopefully we'll be able to convey that. I just wanted to say this because it's been mentioned in the guide, but I think that we need to use patience and wait to the study results, and there has to be a good follow-up across the board, because if we're the negatives that you showed me, we don't even know what we're dealing with. We do have a croupuria, but we don't have much more. So when we know and we see about REC, and when we have a good trial to back this, we will be able to give you more information, and all physicians will be delighted to move to one dose a day and make your lives easier for sure. But you need to use patience. You are totally right. To a great extent is about monitoring, following up well, and having a biomarker in the blood to say, this is fantastic, you can relax. When the only thing we had was croupuria, maybe it's because of the labs, but in Spain we saw that there was a huge variability across labs to perform croupuria. Urine copper levels, and there's a huge variability. So having REC and see the patients, they discussed toxic copper, and I have this. If I have the same levels all the time, that gives you peace of mind. And I also know they're really taking the medication. So there's. So having that is very important. With any chronic condition, moving from 3 to 2, 2 to 1, it's seen with transplantations. We have to give immunosuppressants. Now it's once a day, and the adherence is much greater. So you do this. Because otherwise, if it's more than once a day, they do this for sure in the morning, but then they forget. So this helps with adherence. I have a remark. My brother has Wilson's. He was diagnosed a long time ago, started with 2, 3 tablets and did not tolerate this. And for 5 years, he's been taking one Coupiprant, 1 tablet a day, and the controls are good. Yes, that's what I'm saying. But I need to rest assured, and now I do dare to play around, so to speak, play around, right? Because I have this technique that helps. It has been of the essence for follow-up purposes. Yes, come in. I have more questions about this and about the diet. Luis talked about protein, powder protein, and creatine, and you said that we couldn't take it. And now you see that kind of product in the supermarket with yogurts and custard, you name it. Can we eat that? You want me to answer, to just say the absolute opposite as soon as I'm finished? Fantastic. Well, Faustino, Marina, and myself are not arguing. What we said, if I'm not mistaken, I think Marina mentioned that with a healthy liver, there is no increased risk than the rest of the population. But the population, general population with no Wilson are at risk if the amount is not appropriate, and we don't know what's inside. I've seen patients with fulminating liver failure because they took herbs to lose weight some time ago, because those boxes are not controlled. We don't know what's inside. So I think that's why it was recommended not to eat this. But I don't know what Marina's going to say. I was going to say the exact same thing. So for a drug to hit the market, you run randomized control trials. And these substances are considered food or food supplements, so they do not undergo all those tests. They don't go through that sieve. Studies are done, of course, to study efficacy, but also safety is studied. So when you take paracetamol, it says 1 in every can have liver involvement or kidney involvement, and rare adverse events, frequent AEs. So the labels, you take those drugs out of the boxes. The other day my dad said, "What? I can't even read this." But the letters are so small, and there's so much stuff in here. But with these supplements, you don't know. You don't know. I've had 2 cases, 2, not 1, but 2 of patients with Wilson, because all of that is so much in fashion that my kids want to take that, and they've stopped taking that, or so they say, and I've seen a correlation between them withdrawing that and seeing liver enzyme normalization. But you have proteins on the one hand, creatine on the other hand, but I'm saying that stuff you can buy in the supermarket with extra protein. I'm talking about people who take protein supplements that are sold in any grocery store, in supermarkets, malls. There are tons of them. I don't know, in gyms, you name it, with protein supplement, with creatine to build the muscle. This is very much in fashion amongst the youth, and I've seen patients who were doing fantastic. They were always good, and patients I trusted, and all of a sudden things change. There's an alteration, and everything goes back to normal as soon as they stop eating that. Microphone, please. Microphone, please. Microphone, please. Well, sorry.
Es que soy ectomorfo y me cuesta ganar masa muscular, entonces.
I have trouble building muscle, was the reply.
Y pechuga de pollo sano.
Something about healthy chicken breast. It's cheap, too.
Es que el año pasado también hicieron la misma pregunta.
Oye, una cosa.
Juan. My son, both sons are crazy about that. And I say, hey, you don't need that. Just exercise. Anyway, but the issue is not only with the liver, but also the kidneys, because if they're taking so much creatine, I don't know. Will that have an impact on the kidneys? And we have a kidney expert in the room, so maybe he can shed some light on that. Children and adolescents who come to our office who have some sort of kidney involvement, we tell them, do not take protein supplements, no carnitine or vitamins, because you don't need this. We study folic acid in chronic conditions because it's striking. Or if you look at the figures, the folic acid levels are way below, and we give supplements in terms of iron. There's a functional overload, and you want to have a normal iron reserve in those children, and then something that in Spain is pretty much disregarded, which is bone health, because people eat less dairy products, drinking half a liter of milk, and during growth spurt 750 ml is ideal. That is not what Spanish children are eating. So we normally don't insist that much with supplements. And in the case of children with the kidney involvement, if there's excess protein, amino acids, we recommend not to take them. This is very much in fashion. They sell this at the people who go to the gym. They all take some sort of supplement these days. Carmen, before I forget, I'm sorry to reply, because I just thought of something out of scientific interest, but we've talked about schizophrenia and Wilson before. I would imagine your mother, maybe she had a liver biopsy, and perhaps that has been preserved, and you have the possibility of using methylthionine, and if you get your hands on the cylinder, which is in paraffin, I don't know about Barcelona. I've requested this in Gran Canaria. Marina has this available. Where do you live? Madrid. I don't know. If you mention this, and maybe we can all give a hand with the biopsy sample, if she had a sample done, because she had Hep C. We're not getting this. We need a microphone. But the Hep C diagnosis was way before. So we're talking about 25 years ago. Yes, but there were liver biopsies done on hepatitis, even if it was non-A, non-B. I don't know. I'll think and see where they did that. Now there's a specific tinction. And the hepatologist at my hospital said it's super cheap. But the doctor who saw my mother is dead, too. Yes, but, 25 years is a lot. And indeed, I don't know what the loss is, but pathologists tend to preserve samples longer, regardless of what the loss is. And in my hospital, pathologists say, as long as there's space, I'm keeping this. And a paraffin block is small. It's like a nickel, the size of a nickel. All right, I'll look for it. Another question that has to do with these products, but that can be extrapolated more. I purchased some protein shakes or custard in the grocery store, the supermarket. Occasionally, I only bought the chocolate ones, but when I looked at the ingredients, the cocoa content was very low, but the chocolate flavor was pretty powerful. So the amount of copper, is it that in cocoa, or is it because of the flavorant agents? I don't know. I have not looked at this. It's just each vendor does what they want. So I don't know, maybe they took copper out, put copper in. In doubt, don't. That's what they taught me when I got my driver's license. In case of doubt, stop. All right, so to piggyback on this topic on supplements, those of us who have high cholesterol levels tend to if we're have a high cholesterol, we're almost there. Our GP know that we're taking berberine, marine salt, chrome. All of these supplements that in principle are good to lower your cholesterol levels, apart from omega-3, vitamin B. So should we not take this? Because if I told the hepatologist that I was taking vitamin D, omega-3, magnesium, and indeed, he said berberine could be hepatotoxic, and told me to stop taking it. So is it toxic just for us or for everybody? Well, we have databases that the more products are being bought by the general population, and they cost an arm and a leg. I don't know what, but people are ready to pay whatever. We have a wonderful Mediterranean diet, wonderful cuisine, and people are taking all of this. But there's this website that hepatologists use to look at the toxicity of substances, not in Wilson patients, but across the board. So you can go online, and if it's been tested, it's there. It's an international registry. So what I tell patients, especially younger patients, I say bring the label. And sometimes there's no label or pack insert, and sometimes there's nothing in there because it's not a drug. So you got to go on LiberTox online, and it'll say if there's the probability of it being toxic, or it's been studied and it's not hepatotoxic, or there's suspicion because it's part of a family of ingredients of which your doctor said. It makes sense. If you're not sure, stop taking it. So supplements like vitamin D, which is very much in fashion. Well, in my case, I'm taking it because the blood that works showed that I needed to have this. Then omega-3 is good for cholesterol and to metabolize lipids. In this case, the one I'm taking is pure, and magnesium is pure magnesium. So if they're pure and come with a patent, it's way better if they're pure, because when they're boxes with tons of things, it's difficult to know what the problem is, should there be a problem. So if you're taking one thing and it's pure, if there's hepatotoxicity, you know what the root cause is, so it's way better.
Well, just changing gears a little bit here. I heard that there are 2 labs that do the relative exchange copper, and I imagine it's La Fe in Valencia. We don't do it. We send it to Barcelona, El Clinic in Barcelona, and I think in Madrid it's La Paz Hospital who does these RECs. Yes, the doctor that sees my children came this morning, and the clinic hospital in Valencia, she's going to talk to the lab, and they're very kind. And she thinks that they might help her. So if my doctor can ask the REC in any of the labs that do the measurements, she can send the samples. Well, in my case, in our lab, when we started, the only lab doing these tests was the lab of our friend here in France, and then they started in Barcelona in a clinic hospital, and then the head of the lab services in La Fe, in Valencia, spoke to the head of the lab services in Barcelona, and I think it's pretty simple. They do it straight from the lab, so it's a question of communicating among themselves. It's relatively simple. I believe it's not so easy. I disagree. Well, I'm talking about sending that. Marina, you said that the boss of the biochemistry civil spoke to Mercedes Torra with the head of the service over there. Okay. when you have two heads talking to each other, it's fine, but if your medical director agrees, because in many hospitals it's not so easy. You know, with the regions here, who's paying for these, who's financing that, it's not so easy. I think this is an exception. In the Canary Islands, in Gran Canary, with the highest proportion or prevalence of Wilson's disease in the planet, I haven't been able to achieve that. And they just look around, and we've had publications for Wilson's disease for 25 years. So the reality might be different, but maybe, so it depends on the location in your region, on your hospital. Maybe the head of the service or maybe has a good contact with someone in Barcelona and sends that. Well, in this, here is where patient organizations play a role, because then you report that to the PO, because they are scared to be on the media because they are not performing a specific test. All right, so.
Here.
Microphone, please. Microphone. Microphone. Microphone, Faustino, please. Someone give Faustino a microphone, please. Right. As I was saying, my son, to do the REC, she had to do it. In Almeria won't do it. So since she did it, now Almeria is thinking about that. So we have that problem. It's like the Hill test, you know, this drop of blood and so much noise about that. In Murcia, I think we have 42 to 45 rare diseases. Almeria, we have 28. And if we move to Galicia, I think it's about 63. This is Spain. But there's a difference among regions. 21 in Valencia, all right. So it depends on the region where we live, on the money and resources that they have, so they might act differently. So the patient organizations need to try and win that battle. Then this is us, you know, banging on and whinging. We keep banging on. But I'm sorry, but the clear example is the breast cancer. Have you seen, all this, what happened just in Andalusia? You know, everybody is now trying to, I think the rest of Spain, actually, everyone is seeing that all these mistakes in the systems, and women are dying because of these errors. Obviously, so we should try to work together, because we'll make work easier for them. I'm telling them, anything you need from the patient organization, you'll have it signed. Please don't ask for a loan. We don't have money. But anything else to try and help you, we are ready.
Just to make a comment, I'm sorry to go back to the supplement thing, but just it seems like a hot topic. So you may believe it or not, I started my PhD working with mushrooms, which is strange in Wilson disease. And I read a lot of studies in these things because there are tons of supplements with mushrooms and combinations. And when you look and you analyze the components, the correlation between actually the analysis and the label is completely different. So be very careful with this kind of supplements, because many times they, like 80% that's in there, it's not in the label. Especially when we are talking about trace elements, copper, iron, zinc, calcium. Rarely you have this on the label. And what I saw in many studies with mushroom supplements is that it is very, very dangerous, especially if you have a condition where you need to keep certain things under certain levels. And for example, our intestine, it regulates very well what it absorbs. So in many cases, you may take, the other day I checked an Instagram page of this actress and she was taking like 20 supplements. And she put a photo, this is what I took in the morning. That is just money for the bin, because 90% your intestine will not take up, okay? And if you really need a supplement, for example, my husband needs to take vitamin D, but this was prescribed by the medic. So he's taking vitamin D, 1 pill a month, and this was prescribed by the medic, okay? So, because, and actually this was very terrifying for me, these studies with mushrooms, so people, please take care with these things.
It's very interesting because, in fact, we had, I'm talking 10 years ago, we had a lot of cases in Spain. Suddenly we had a lot, not in Spain, everywhere in the world we had cases of fulminant liver failure. We started investigating, and it was related to a company. And the company was selling compounds with names. I can't remember. Energy, so it would be energy 1, energy 2, energy plus, strength 1, strength 2, strength 3. So strength 1 in Spain had some components which were very different to strength 1 in France and strength 1 in the United States. So if you looked at the specific components, analyzed the components of the same box with the same name, it was different here. So it was very difficult to understand the cause and assign causality because the components of the same name were different in each country. Terrible. Terrible.
Conclusión. Pues yo también voy a cambiar.
All right, let me just change subject here, since we have Gloria here. And for many years, we've been following the development of the studies that you've been directing or overseeing in gene therapy. So please update us in where we are right now and what's ahead of us. I think it's quite interesting for us. Okay, so you're making me work. Okay, let me just tell you, summarize a little bit. Over 10, 11, 12 years of work, and I don't want to discourage you, but I think, what's your name? Jose Antonio. All right, I think we've been just chatting a little bit, and we've been talking many more times. Thanks to the Foundation Per Amor al Art, we started the gene therapy project with the vectors that Pasquale talked about, the adenoviruses, and we developed this smaller gene that could fit in. We conducted all the studies that you can imagine. In mice, we showed that they worked. Mice get cured when we inject the adenovirus. They stop being sick, and they are perfectly normal, especially when we treat them at an early stage. Situation changes when they are older and they have any other disease. But even in those conditions, we improve the liver status and we can reduce the concentration of copper in the liver and even in the brain. With all that information, all that helped us to start this clinical trial, still ongoing, treating 4 patients. It was so hard to recruit the patients. You just can't imagine. And this was just another one of the reasons why those who have to fund them do not invest, because it took us more than 3 years to recruit patients. Okay, things got complicated with the pandemic. It was very hard to enter the hospitals. But this is not a clinical trial being conducted in Spain. It's being conducted in various places in the world. It was initiated in the United States. But the regulatory agencies, when we showed the clinical trial, they, within the inclusion criteria, they allowed us to put patients that are nearly healthy, are practically healthy. Why is that? Marina said that the clinical trials are after the safety in the treatment, and the aim is that the patients that you are treating have the least odds chances to suffer any side effects. What if you want to conduct a clinical trial with patients that are healthy with the treatments? Nobody wants to take the risk of having a virus being injected into their bodies because they are scared and you don't know what's going to happen to you. So there's a lot of uncertainty. So I understand that from the patient standpoint, it would be hard to enroll in these studies. But basically, you need a lot of financial resources to conduct this clinical trial. The vector you're using costs millions to produce, and I'm not exaggerating here. The clinical trial itself costs millions as well. So we treated 4 patients. We haven't seen very clear data in terms of efficacy, a little bit of elevated ceruloplasmin, and slight sort of descent in the copper in urine, and they had to stop because it was not going to be cost effective. That was not the main reason. I think if we had had spectacular results, maybe things would have been different. But Pasquale said that this is not the best of times to develop advanced therapies that are costly in rare diseases. Even treatments or therapies that work, that change lives, that really change lives, are being sort of discontinued by the companies because the social security of the countries is not funding them or reimbursing that. So it's quite discouraging to us because after many years of research, this is a research that is aiming to change lives. Our goal is not curing mice, and I keep repeating that. So right now, in our field, in our respective fields, we're struggling to change that trend. Next year, with this crystal ball, what we want to do is to change the trend. The governments, the regulatory agencies that foster these treatments, otherwise we will not get to the results we intend. We have understood what the problem is. We need to understand what the problem is to take the right decision. So I believe that in the coming years, taking aside that the technique is improving quite a lot, within 10 years we have the updates and developments have been spectacular. You know, things that 2 years ago were at the forefront now are obsolete. So in gene editing, I believe that we're going to be able to change the genome, the DNA, the information of the patients, and this is going to come. But why, if this cures a mice, showing that this is fantastic, if I will never have patients to treat or an administration supporting or backing that research? So we need to change, obviously, and as we need your support. We need you to request for that, because if I go there, I'm going to ask for financial resources for me, for my work, but I need the patients backing me as well. Okay, maybe last question, or maybe, are we done? Microphone? Microphone?
no sería enfermo.
Although, if I had this adenovirus, I don't know. We're sorry, we just got the last bit of sentence. So, with these final words from Juan Antonio, we conclude this discussion. Okay, there's no break, so we are going to continue. Thank you very much, Gloria, Luis, and Marina, for your contributions.